that. Thanks to the dean. To the dean.
Okay, and I think we have another. I'm sorry that we have a little more time to this translation, but now we have. I invite our second speaker, Prof. John Murphy, and he will speak about social problems and community-based epidemiology.
Well, what can I say? I just want to say one thing. I mean, you have to understand, I've known Mickūnas for 41 years. That's longer than I knew my parents. And when I was a student, and then since then, you can imagine that's a lot of collaboration. That's a lot of articles. That's a lot of projects. That's a lot of conferences. How do you ever repay something like that? I mean, it's impossible. So all I can say is thanks. With that in mind, I have to admit, though, that I was not a very good student. In the sense that I'm heading to a philosophy department with an idea in mind that philosophers up to this point have only interpreted the world. The point is to change it. And so you can imagine that created a lot of situations. Because I'm almost encouraging as far as like doing what students are supposed to do. And so when I finished a master's degree and students were heading off for PhDs, and I was bummed out that I didn't do this because my other friends were all doing this, I headed off to communities to start working in communities. I eventually got a PhD, but I never imagined I would ever be a professor because I was trying to change the world. And the only reason I ended up in a university really is because of Ronald Reagan. Because when he became president, he cut back all types of social services. There was no place other to go than to the university. Now, it's been a good thing. I'm not saying it's a bad thing, but you know that's not my vocation in a way. So even there, it's problematic because most of you know what universities are like. So anyway, what I want to talk about today is what I've been doing for the last 10 years. I started working in communities in the United States, and now I've spent the last 10 years working in communities in Latin America. Most recently in Ecuador, but I've worked in Colombia and other places. Mostly establishing or trying to develop health programs. And so you'll see from what I'm going to write, I'm going to read here, the influence of philosophy, Mickūnas, and all this is going to be obvious. So I don't have to say this over and over. I mean, it's just going to be obvious. But the idea was always been looking for some type of philosophy that was compatible with what's being called now sort of a community-based approach to health delivery and healthcare. For many of you who are not into this field, in 1963, in the United States, President Kennedy, in the fall of 1963, a law was passed called the Community Mental Health Act. Later, similar acts were passed in Britain. Other acts were passed in various places that said that you were supposed to deinstitutionalize people, in other words, get them out of these institutions they've been in, and that they would be treated in what was called the least restrictive environment, which meant their communities. The problem is that type of orientation really lacked a theoretical base. Most of it was directed at deinstitutionalization. The idea is we have to get people out of there. But there weren't any, really, in my opinion, very philosophies around to give an orientation to what was going to happen. So what I'm going to do in this paper here is talk to you about some shifts in theory that have taken place from traditional epidemiology to what's called the new epidemiology, and then this approach to community-based epidemiology. It's this community-based approach that I've been using for the last 10 years. And I think it's, frankly, I think it's the only way to go at this, but that's for you to judge. So with that in mind, let me just read a little bit here, give you an idea of what's going on. So the introduction. Epidemiology has been a regular part of traditional social planning. In this case, the general idea is to determine a level of a problem in a certain geographical or social region. Calculations are often made, for example, of the indice and spread of disease. The field of public health has not been exempt from this trend, but many analysts believe that these modes of assessment are abstract and reductionistic. For example, communities are treated as if they represent clusters of social economic traits. Furthermore, certain cultural features and psychological properties, such as motivation or possibly moral character, are linked to the empirical characteristics of the environment. The so-called new public health rose against this strategy to design and implement more socially sensitive assessments and interventions. Some critics contend that this approach could be traced to the Lalonde report issued by Marc Lalonde, the Minister of Health in Canada during the 1970s. In this document, the idea was broached that the medical model may have severe limitations, specifically with regard to prevention. But for the most part, communities are still treated as natural sources of data, with little emphasis placed on how persons define their problems and possibly remedies. The strength of the new public health, on the other hand, is that communities are viewed to be dynamic and intricate, with rich cultures and knowledge bases that influence perceptions of health, illness, and successful interventions. In general, the general thrust of this change is that communities are portrayed to be complex and should be investigated more closely than is possible when the focus is on empirical indices. I keep using this term empirical indices because I am referring to empiricism, but there's an approach that's used that's called social indicator analysis. And so I want to let you say you know that. For this reason, the program of the new public health is often associated with community-based planning. Nonetheless, this characterization may not be correct. Although process and context are incorporated into this new orientation, how a community is constructed is ignored. To become community-based accordingly, advocates of the new public health epidemiology must begin to appreciate the embedded nature of all social phenomena, including disease and cures. With all health behaviors mediated by participation, and therefore socially constructed, reliable observations must emphasize more than the empirical qualities of persons and their environments. Effective interventions accordingly depend on epidemiology becoming more attuned to the interpretive character of a community's reality. In other words, a life world. Traditional public health. The guiding principle of traditional public health model is the identification of so-called at-risk populations. The task is accomplished by trying to specify the factors that have contributed to this condition. Standard empirical reference such as age, education level, income, and geographic location, for example, are invoked to calculate the likelihood that a problem will emerge in a specific population. Associated with these empirical indicators are assumptions about both the presence of pathogens and the buffers necessary to forestall the onset of an illness. A neighborhood with low level of education and high unemployment, for example, is considered to be problematic, or a high-risk location. Eventually, a cause-effect onset matrix, which is a phrase they use, is established along with probable outcomes of various interventions. In effect, an algorithm is introduced with certain values attached that have specific parameters. Following the introduction of a range of inputs, such as income levels, education, or quality of housing, comparisons can be made between communities. Profiles can thus be established to specify where social problems are likely to arise. Clearly, this methodology represents the worst sort of number crunching. Variables are decontextualized and given exact identities, stripped of any contingencies. The end product is a statement of probability about the likelihood of an event occurring in a particular locale. The imagery that supports this kind of analysis is very realistic. Terms such as barriers, structures, networks, and system, for example, are used to describe communities. Additionally, diseases are managed to travel along certain channels, through specific networks, and reach certain barriers. In fact, the standard epidemiological assessments the principle of natural causality is thought to be operative. That is, specific empirical elements are thought to foster or cause certain outcomes. The point in this regard is to discover these variables and their connections. Furthermore, most of these linkages are described in biological terms. What could be more concrete than such a portrayal? Although biological descriptions are metaphorical, they portray the social world in very believable terms. Like a body, a community can be described to respond in various natural ways to determinants. Due to this mode of calculating risk, traditional epidemiology is often characterized as operating within a black box. In this regard, only elements that can be readily observed are introduced into analysis. Furthermore, anything connected with subjectivity is thought to be fuzzy and unreliable. All determinations are the result of inputs that are arranged by mathematical models to generate output, or what they call risk estimates. In essence, what occurs is that an examination of substance is equated with understanding. In other words, whatever can be measured becomes the focus of attention, while other sources of knowledge, are ignored. The personal or collective experiences of these so-called objective factors tend to fall into this latter category, because this dimension is thought to defy rigorous measurement. What is overlooked in this imagery is the actual interaction that constitutes and sustains a community. How persons relate to one another and possibly facilitate or retard the disease process is equated with structural factors that are presumed to either transmit or inhibit the spread of a pathogen. Using terms such as impact and outcomes, for example, tends to conceal how perception mediates social existence, even the onset of disease. The point of this critique lodged by community-based planners is that factors do not simply impact on persons. Certain conditions likewise do not necessarily produce particular outcomes. But even within the traditional epidemiology, an attempt has been made to temper the prevailing determinism. Take, for example, the traditional, what they call epidemiological triangle, which consists of hosts, agents, and environmental factors. The basic idea is that the disease onset involves a host who has an effect on this process. But it should be noted in terms of this triangle, how persons interact with their environment, and what should be noticed in terms of this triangle is how persons interact with their environment and one another. But in the end, the models adopted by traditional public health provide concrete but socially uninformed descriptions of so-called illness behavior. In this regard, causal statements are provided that specify the relationships between, for example, environmental degradation and illness, without giving much attention to how persons perceive their environment, evaluate their health, or decide to pursue health. The final product of this outcome is the formulation of, again, what they call a web of causality, and thus a broad picture of disease onset. But clearly at no time is any serious attention directed to how persons construct their lives and their social worlds. The new public health. The aim of the new public health is to avoid the reductionism linked to the traditional epidemiology. For this reason, an ecological strategy is adopted, sometimes known as eco-epidemiology. The general critique of the traditional perspective is that the parsimony in building models may improve clarity, but is also misleading. The entire social world, in fact, is overlooked. Just to say something, what's going to happen here is, and this is why I'm sort of concerned, because there was a lot of talk in the last couple of days about holism, for instance. Holism may not go far enough at all. And that's why I wanted to just make you aware of that, what this critique is coming up. Within the ecological framework, persons are understood to be part of a seamless web of influences, including physiology, psychology, culture, or the economy. In this regard, Engels' well-known call for a bio-psychosocial agenda is representative of this trend. Due to this ecological perspective, the isolation of risk factors is no longer the guiding principle in any judgment of need or remediation. Indeed, social indicator analysis and the underlying empiricism is thought to be myopic. Explanations of behavior, according, are expected to be holistic and take into account how persons interact with their surroundings. The phrase that is being adopted to capture this sentiment is person in environment. In this sense, persons and environment are not two separate variables. Instead, through participation, persons are understood to alter themselves and change their surroundings. The point of this ecology, therefore, is to extend any investigation in at least two directions. At the individual level, persons are presumed to have a life course and are approached in a holistic manner. Instead of passing through developmental stages ad seriatim, cumulative effects are considered to be important. In this regard, the effects of life are thought to be accumulative. The past, for example, is not a moment that precedes the present, as in typical causal analysis, and merely a distant influence. Rather, because persons engage their lives, the past is carried forward through memory and deeds. Salient factors are thus selected to be part of the community's collective present and should be understood to influence their current behavior. On the other hand, persons are envisioned to exist in an environment. As a direct challenge to dualism, a web of influences is assumed to be operating. Persons exist, for example, in a family, school system, and workplace. These factors, furthermore, interact with their inhabitants and with one another. Multiple descriptions of parallel interventions are thus required to address adequately any problem. Any assessments and correctives must be focused and sufficiently comprehensive, but textured and situationally sensitive. A person and environment strategy is thus vital at this juncture of inaugurating an intervention. This attempt to add breadth to epidemiological analysis has been both welcome and productive. Clearly, better analyses and effective interventions can be undertaken. For example, the introduction of a sociological dimension has had the effect of explaining both health disparities and between ethnic groups, and the promotion of well-being that has been very illuminating. Variables related to family life and the workplace, for example, are included in most explanations of disease onset. Recognizing the importance of situational factors such as these seems to make sense to almost everyone. The obvious aim of this ecological holism, as indicated by Kelly and others, is to become attuned to the social and cultural considerations and perhaps gain some insight into their interaction. The problem, however, is that ecology has not necessarily abandoned empiricism. As a result, process is mistaken for biography. This is a crucial element. Ecological models, in this sense, are comprehensive, but deal with variables as if these factors represent the empirical features of a community. Standard variable analysis, simply put, is merely expanded in these models. Another consideration is that ecological models convey a sense of naturalism. That is, like the physical environment, the social world appears to be integrated with all parts naturally related. These connections between elements appear to be almost biotic. The problem with this analogy is that social life is deanimated or transformed into a myriad of objects that are connected by inviolable laws. This is going to be ending soon. It's coming. Community-based epidemiology. Because a community is not simply a place or a collection of empirical traits, but a collectively constituted reality, a new approach is needed to epidemiology. Neither process nor social indicators, accordingly, are appropriate sources of information. Everyday life in a community is much more complex than is revealed by typical epidemiological data, even when these variables are placed within an ecological context. Due to the fact that communities are constructed or existential, biography becomes important. The tales these persons tell about themselves hold the key to understanding their constructed world. Nonetheless, empirical data should not be dismissed completely. This is a big argument among people. I've had this argument in Ecuador and various places. For example, knowing how many persons have been vaccinated in a community may be helpful to determine when or where an outbreak of a disease is expected. Likewise, education level might provide some insight into the knowledge base that persons have about a particular disease. At the general level, such empirical data are often useful with respect to gaining the attention of planners or government officials. Clearly, economic deprivation and illness are related. But in terms of understanding the course of a disease, how persons will react to health issues, a lot of vital information is missing. Because of the influence of participation, a community is pervaded by definitions, expectations, and perspectives. A disease does not spread accordingly through natural channels or networks in a mechanistic manner, but is perceived and assessed before any problem is thought to exist. According to Ade and Anderson, a disease is mediated by a host of considerations before any problems are identified. Disease does not simply arise, in other words, as a response to environmental conditions, but is embedded within certain values, beliefs, expectations, commitments, and so forth. For this reason, a community-based epidemiology does not involve merely a surface examination of a community, since definitions and the commitments, for example, are not empirical and are not simply recorded. Gaining insight into biography thus requires more than periodic consultations with a community. Hence, the thrust of a community-based epidemiology is not simply to chart changes in behavior, but to determine the meaning of these actions. For this reason, Gareth Morgan declares that community-based approach is guided by perceptions, values, and belief systems. In this sense, rather than merely describe, community members provide access to how they construct their understanding of disease. This is a crucial element. This has led to what people call sort of a type of participatory action research, where the people in a community are involved in every facet of a research project. And this is what we were basically doing, trying to establish health communities, health committees in the various communities we were in, who would then serve as the connectors of any physicians happen to come by, and to provide guidance to what was going to go on here, to identify the problems and so forth. Because the research shows, I mean, when Joe and I were in Columbus, we actually published a paper where we showed that if you go to a community and ask them what are the problems, and you go and ask the experts what they think the problems are, they're absolutely reversed. And so you can imagine all these experts that are making these determinations about what are problematic in communities are acting on beliefs that don't coincide at all with what's going on in a community. I mean, literally, when we gave these checklists, to community members and to experts, the beliefs about the problems in the community they were supposedly representing were absolutely reversed, which is absolutely incredible. People wonder why in Washington and other places policies are developed that no one pays any attention to. So, in a sense, for this reason, a community-based epidemiology does not involve merely a surface examination of community. Okay? In a sense, rather than merely describe, community members provide access to how they construct their understanding of disease or cure. That is, intense collaboration is necessary between planners and a community if the biographies of these persons are going to be adequately appreciated. But engaging a community is not a value-free endeavor, but requires dialogue and commitment. In this sense, those who construct a reality will not necessarily share their knowledge with anybody, given the intimate nature of this knowledge. This is what I always wondered about sociologists. They're like voyeurs. In a sense, they want to, they expect people to tell them their intimate things about, their health and so forth. But it's like if somebody would walk up to you on the street and say, do you have syphilis? And you're going to say, oh, absolutely. It's just not going to happen.
How many times?
Yeah. So,
Second is, would you like syphilis?
So this is a special sort of relationship is crucial to gaining access to this privileged information. After all, biography of a person or a group is a precious story that is often very guarded. Empirical data on health status, for example, are quite superficial when divorced from past experiences, perceived capabilities, or future expectations. Likewise, the likelihood of pursuing a treatment is not mere a matter of having information at hand about disease onset or progression, or even knowledge about sufficient resources, but relates to how health and illness are perceived and evaluated. In this regard, Richard Zahner made an interesting statement. He says, perhaps health is maybe the most existential characteristic people have, which I thought was sort of interesting when he said that. How social factors, such as resources, accessibility, and seriousness, how social factors, such as resources, accessibility, and seriousness of a problem are valued and prioritized contribute a lot to whether a treatment will be sought. Placing variables in an algorithm, on the other hand, distorts how persons make decisions about their health. Rather than trying to optimize the rationale of their decisions, they base their actions on expectations that relate to collective memories, past experiences, and the perceived chances of success. The general point of community-based epidemiology is that health status has little meaning divorced from the biography of a community. Nonetheless, biography extends beyond holism. For example, the identification and spread of disease does not represent a natural progression or a causal connection between events, but often includes value judgments and a willingness to act. It's going to be ending shortly. I won't read the conclusion. This personal or collective mediation is what community-based planners have in mind when they claim that a disease does not necessarily follow a well-trodden path. Here again, realist imagery is deceiving. Nonetheless, many persons tend to think that a path is a fairly routine and unencumbered mode of transmission. But barriers to health are not necessarily natural or obvious, such as a lack of resources or transportation, but reflect judgments about the seriousness, probable impact, and the choice of remedies at hand. How persons might respond to a health threat, stated simply, is not revealed by reviewing social or environmental indicators, even in a holistic manner. The course of a disease, accordingly, is anything but routine. Planners should not be lulled into thinking that healthcare will be improved if the proper path to treatment is cleared. This type of imagery is used constantly. That is, the typical structural barriers are removed. The task is not so simple. Even supplying the best resources may not be productive if a community believes that poverty and related diseases are merely the part of life that should be endured. And I just had a student in the Dominican Republic completing a dissertation on this type of idea, and this type of theme comes up constantly. We're getting it. Every path to healthcare, so to speak, is potentially unique. The job of a community-based planner, therefore, is to extend beyond causation to grasp the process of disease creation. The use of the phrase disease creation is intended to convey the idea that a disease does not occur until an issue is defined as problematic and persons become motivated to deal with this phenomenon. Once these matters are settled, an entire disease context arises that identifies resources, accessibility, threat, and other relevant themes. A recent response to this omission has been the development of what Phil Brown and others call popular epidemiology. Basic to this strategy is that average citizens bring to the attention of planners specific problems that are being overlooked by these experts. These local persons accordingly give the needed directions to any epidemiological studies due to their familiarity with the situation. As reported by Brown, this strategy has been helpful in correcting the effects of pollution related to environmental degradation in several cities. Consistent with community-based philosophy, the idea is that these neighbors help to guide and motivate properly professional epidemiologists. Okay, well I have a conclusion, so I'm not going to read it because that's too much time. All I want to say is that this, from my experience with this, this has been very effective. I hate to use the term empowerment because I think it's paternalistic. After going to Ecuador and dealing with these people in communities, I refuse to think that I'm going there and empowering them. They already have the power, except it's been sort of removed, diffused, degraded, and so forth. So now the idea is that communities basically can begin to control their destiny. And the whole term that's used now, of course, is providing health care with dignity. And that's a key phrase in Latin America. It's used a lot to talk about how this should be done. Well, thank you.